life.
Perfect. Right.
Socially and social aspects also.
Correct. Roshan, I again lost the rights. I'm really sorry, Roshan.
Okay. Still you can't.
No, I cannot.
Uh,
Would you like to do it for me?
yeah, sure. 1 minute.
Thank you. So there are certain aims for treatment. These aims, as Ramya rightly said, we are looking forward for our patients' good health. We are trying that the patient is not going back to the relapse. We are looking for his social well-being. And at every stage, we are trying for wellness mentally, physically, and socially, which is we are looking for a holistic health. Roshan, are you sharing? Yeah, thank you. Next slide, please, Roshan. Thank you. So aims include stopping or reducing drug use, improving health, well-being, social functioning of the affected individual, preventing future harms and relapse. Am I clear?
Yes.
Next slide, please. So there are certain principles. There are certain principles which are written in this booklet, which I had shared the image of, written by WHO and UNODC. It has 7 principles. While I was sharing it, I wanted it to be a little bit of interactive, but probably Roshan is not able to do it. Can I request somebody to read principle 1?
Treatment should be
Available.
available, accessible, attractive, appropriate.
Yes. So the first principle says it has to be available. Available means it should be available at primary health center, at secondary health centers and tertiary health centers. It should have outreach facilities and should be available with various resources. Accessible. Would somebody like to define accessible?
Accessible to me means that in spite of financial constraints, or if the person has a little isolation also, it should be accessible to them.
Yes. And the other thing is, it should be accessible means it should be connected to public transport also. Like the treatment center should not be at some remote part of a rural area where people cannot go. So there should be a connectivity by road, which is very important. Attractive.
Attractive for me is creative and suit to the people.
Perfect. Attractive, and it should not bear any sort of stigma. So people are comfortable walking in. Appropriate.
It should address the problems rather than what the individual is actually facing. It should be able to address the point out the problems there. I guess that's what
Appropriate. Is it means indicating the ethical issues, ethical sides?
So there can be many things. Like as Raman sir said, we can add that point here in appropriate, as it should be financially suitable to the patient's need. It should have cultural appropriateness. It should, it should be appropriate by time. So if somebody is going to our office from 9 to 5, we cannot have an office hour of a treatment center from 9 to 5. So by time also, it should be appropriate. Is it clear?
Yes.
Principle.
And also Shalini,
Yes,
if
sir.
I may add, see, appropriate also means the treatments planning must be based on the level of addiction this person is in. I mean, if
Yes,
it's just
sir.
early stages, then it should be a brief intervention, or
Yes.
a little longer intervention, or a very long intervention, depending on the state of the person.
So as you rightly said, but this component is part of other principles which are stated later in like principle 3 and principle 4. So what this WHO guidelines explained here as appropriate means, it clearly mentioned time appropriateness, and it should be culturally sensitive. I'll share the handout once I'll just finish this presentation. I'll share the handout on our WhatsApp, or probably I have shared it also. Now, principle 2, can somebody read it for me, please?
Principle 2, ensuring ethical standards of care in treatment services.
Yes.
confidentiality, patient's dignity, respect for human rights, no to discrimination or stigmatization, no forced treatment, patient's autonomy, accurate and up-to-date clinical records, no to degrading interventions, and code of ethics for staff.
So these key terms are components of the principle which says ensuring ethical standards. When we talk about ensuring ethical standard, it means confidentiality, which we being professionals have to ensure at every point. Let it be principle 1 or principle 7. Confidentiality of the patient has to be maintained at every stage. Patient's dignity, human rights, discrimination, and stigmatization. What does it mean, no to degrading intervention? What does that mean? Any idea? So, yes.
Means uh, uh, as a counselor, I cannot degrade the intervention given by another counselor, like that.
Okay. Also here, like we cannot punish our patients. Like we cannot just like avoid giving them food or handcuff them or, lock into a particular room and not allow them of other facilities. So degrading intervention means we respect their human rights and we let them live like a human being rather than making any sort of hindrance in their day-to-day life. Am I clear when I say this?
Yes.
Code of ethics for staff. Ramya, are you saying something?
No, no, no. I said yes to what you said.
Can I change the slide? Thank you. Roshan, next slide. Principle 3. Would somebody like to read it?
Promoting treatment for drug disorders through effective coordination between the criminal justice system and health and social services. Access to treatment.
Yeah.
Access to treatment and social care services for people within criminal justice settings. Treatment intervention should not be imposed in criminal justice system. Training for enforcement law agency, criminal justice system staff, and people involved. Evidence-based guidelines. Ethical and professional standard as in the community. Efforts to reduce stigma and discrimination.
Would somebody like to explain this principle? This is one of my favorite principles. So it says when we talk about criminal justice system, something that comes into mind, a person who's a criminal, who has done some sort of crime, probably a murder or probably a rape or something which is like major. And when this comes to our mind, we think of like punishing him the severest. What WHO says is, despite that person being a criminal, as a professional, we need to ensure that his human dignity is intact. All the treatment intervention, if we are trying to attempt, that has to be with the consent of the person who has done the crime or who is behind the bars. Once the person comes out of the bar, we need to ensure continuity of care, and that too only with the consent of the patient. We cannot enforce anything on him without his autonomy or without his permission. The kind of treatment that we are giving has to be evidence-based. We cannot interfere and give them anything just because probably he has done a crime or probably somebody has attached a stigma and somebody is discriminating it. So at every point, the stigma and discrimination is coming in each and every principle. I would not further repeat it, but at every principle, WHO has clearly mentioned we have to ensure to reduce stigma and discrimination. Next slide, Roshan. Thank you. Principle 4. Raman sir, would you like to read it?
Yes, okay. Principle 4, treatment should be based on scientific evidence and respond to the specific needs of individuals with drug use disorder. Evidence-based intervention as in other medical services. Multidisciplinary team, tried and tested treatment, and traditional system intervention.
So this principle says that we have to give a tried and tested treatment, which has like already approved the clinical trial. The need based, it has to be need based. We have to tailor the treatment as per the unique need of our individual patient. If some culture approves certain sort of traditional system, we need to encourage them to move ahead and try to adapt evidence-based practices. Principle 5. Principle 5 says, somebody.
Responsible to the special treatment and care needs of population groups, subgroup, children, adolescent, women, migrant workers, sex workers, elderly people, etc. Tailored treatment as per their unique needs, social assistance and social support packages, outreach services.
Perfect. Here we meet the subgroup. Already we have spoken about this in principle 4, that subgroups, like these are the various subgroups and there can be many other subgroups also. Can you name few other subgroups apart from these that are mentioned in the slide?
LGBT.
Right, LGBT. Anyone else?
Refugees.
Refugees. Right. So there are various other subgroups. Now these treatment has to be based on these subgroups. I'll take a quick example of a women. Women being a vulnerable group in the society, they are like forced to for domestic abuse, sexual abuse. The treatment for women has to be based on all the problems that she faces or all the things that she goes through. So it is not just that we just put her in a common treatment center and start treating. So there are various other factors that we need to look into, and also we need to ensure social assistance and support packages. Am I clear? Any question?
No.
Thank
Yes,
you.
you are.
Next slide. Principle 6, ensuring good clinical governance of treatment services and program for drug use disorder. Now, this good clinical governance here means that all the policies that the treatment center is planning or is giving has to be relevant and approved by the relevant government. You cannot just any day add any policy and start the treatment. It has to be approved by a relevant government. There has to be proper coordination among all the staff that is linked, and that is those who are working in the treatment center, and all the staff have to be well qualified professionals. What I liked most about this principle or about the entire principle is the staff care. So, treatment is not an easy process, neither for the person who's walking in nor for the person who's giving the treatment. So, this principle talk about staff care. It is very important for the people to look for the staff, because the staff is taking so much of pain, grief, and many stories which probably he or she is not able to handle. So, it is very important to look for our staff and support if any sort of need is required by him or her. Adequate funding so as the treatment is not interrupted at any point. Feedback should be taken, including patients' feedback, to improve the treatment facility. This is the last principle, principle 7. Nima, would you like to read it? Nima, would you like to read it?
I can read.
Yes, please, Jyotima.
Principle 7. Treatment services, policies, and procedures should support an integrated treatment approach, and linkages to complementary services require constant monitoring and evaluation. Holistic services, integration of different services, equipped monitoring and evaluation.
Thank
Less
you.
than 2 minutes, okay?
Thank you, Sevati. So this is just crux of all the principles. All the principles finally should lead to holistic services. A patient who's walking in should get all the sort of services, maybe in the need of psychiatric, psychosocial, or some specialized healthcare, probably HIV, TB. So the treatment center should have connection with other services. So if need required, he or she or the patient should be provided with the relevant services. And a continuous monitoring and evaluation is also required, which should monitor the kind of treatment the patient is getting and its result. Here I complete with all my principles. Next slide, Roshan. Thank you. We have a Padlet. Roshan, can you please share the slide for the Padlet? I hope it was not boring. So
was good. It was good.
Thank you. This is a Pedlet. We have spoken about few key terms. I would request everybody to add one key term into these seven. We need to like scroll it. Roshan, you need to assist us. There are 7 principles. And I would request everyone to add one key word to each principle if possible. We just have 15 seconds. Probably we can get quick 15 words.
Do you want to control?
Anybody can add.
No. No, do you want the control?
We are not able to add.
You should
You
give
can't add like
control
that.
to everybody. Everybody
Not
should be.
everybody, just one by one I can add.
So can I request for one more?
Confidentiality.
Okay. Can you try now?
Confidentiality.
No, we cannot
Yes.
add.
Never mind. We'll just do it later, probably. I'll share it on the WhatsApp group and we can do it there. Thank you so much for your time. And I hope I did justice to the topic. Thank you so much. Over to you, Equalink.
Thank you, Shalini. I can't, my computer is not taking my face today, so I can't show you the face. But I hope you can listen, you can hear me well.
Yes, ma'am. Yes, ma'am.
Okay.
Yes, ma'am.
So you were very clear diction, explained very well, made it very interactive. I like the way you asked people to read and then asked them some example. You even elicited a few examples from people, what they think about it, which is very nice. You gave a lot of examples for every principle. I like the way you were going to use the Padlet, but maybe there are technical issues. We need to learn these things, practice it. And in 15 minutes, maybe it was a little challenging for you to do that. But then that was a good effort. So good show, Shalini.
Thank you so much, ma'am.
Yeah, Shalini, absolutely good. You presented it in very well way, took the exact time, tried a little bit of technical these things, but that could be possible when everybody knows the technical side of it. The way you spoke was very clear, simple language, but very crystally clear language. But I would like to ask you a question.
Yes, sir.
The principles, that 7 principles you taught, by which organization?
So WHO and UNODC. I mentioned that in the very first slide.
Okay. But NIDA principles?
So actually, UTC had given us 3-4 principles and NIDA has 12 principles. So
13.
I asked Thomas sir and he said to make it minimum. So I just started with WHO only. Thank you.
Okay, very good. I just want to clarify, that's all. Okay.
Thank you, sir.
Very good. Very good.
So much of noise here, Shalini. I will give you my feedback separately, individually. Is that okay?
Yes, sir. Perfect, sir.
Traveling, a lot of music and all here.
Perfect,
You
sir.
need a-
I'll be waiting. I'll be waiting for it, sir. Thank you.
I only meant if you don't get time to present all the 12 principles, at least to do some 6, 7. Yeah, that's
actually,
how I thought. But it is okay. Even WHO
WHO
principles, now it goes very much, yeah, it's fine.
So WHO
Good job,
has
good job. Huh?
elaborated
I'll get back to you
principles.
later.
WHO has elaborated principles and NIDA has probably broken it into simpler principles and made it 12. So I thought that it is better to explain these 7 principles and let it be like this way only.
It's fine, it's fine. For ICAP exam, of course, be prepared with the NIDA, no? Because they are the one who are conducting.
Absolutely,
Okay.
sir. Thank you.
Okay then, huh? Okay, see you. All the best. I'll get back to you again.
Thank you.
Who's going next?
Ma'am, me?
Ramya, go ahead.
Yes, ma'am. Yes.
Ramya,
Yeah. Take the
All
floor.
the best, Ramya.
Roshan,
I'll share
can
the
you
slide.
just, yeah.
Wait, one.
Yeah, so am I audible to everyone?
Yes, Ramya, you
Yes, we
are.
can hear.
Yes. Thank you. So, good evening, everyone. I'm Ramya, and today I'll be presenting the topic, which is consequences of substance use. So, before we proceed on to the next slide, I would like any one of you, anybody who can tell me what all can be the consequences that you can think of when it comes to substance use.
To really break down.
Hallucinations.
Yes, hallucinations.
Physical, psychological, social, or in all aspect unmanageability.
Yes, very correct. Roshan, next slide, please. Yeah, so as Sabati and Avjit said, individuals do suffer from a wide range of consequences. And for the ease of convenience, we can sort of categorize them under these four. The first one being medical, the second legal, third social, and fourth economic. So can anybody tell me what can be the medical consequences of substance use?
Liver problems, uh, other health problems.
Yes,
What?
very right, Clara.
Memory issues, memory
Yes,
problems.
yes. All of you are absolutely
Accidents,
right.
accidents,
Yes,
injuries.
They can
yes,
develop psychiatric issues.
yes. So, the medical issues, the first and foremost thing that we understand is a person who has been abusing drugs, his or her immune system will be compromised. So, as a result of which, they will be prone to many medical conditions or illnesses, and some of them are like HIV and hepatitis C, tuberculosis, and also HIV for the reason because there is a risky injecting here. You share the needles, so you don't know what you're contracting from whom. So there is a risk of that, and tuberculosis and hepatitis C, as we said. And the second one, the legal consequences. Can anyone tell me what can be the legal implications here?
One is
Crime.
you need to indulge in criminal activities like theft, etc. For that, or in divorce, etc.
Yes, very
Come on,
right,
Wilson.
Avjit.
Also, trafficking of drugs. That is also.
Yes, very true, Devika. So basically, the use of illicit drugs carries some of the most severe legal consequences. And the crime rate is also, the because you are under the influence of the substance, you involve or you engage yourself in some sort of fights where you injure yourself or others. And also, people who become addicted to some substances, they sort of not only compromise or risk their physical well-being, but also in a way they sort of cut down their future by either paying hefty legal fees or let's say crippling prison sentences, all of it. And can anyone respond as to what can be the social consequences here?
Isolation, not attending any functions, family get-togethers.
Yes, very true,
Violence.
Chatura.
Violence.
Indulging in
Yes.
assaults.
Yes, very rightly, correctly said. So, because people who abuse substances, they are sort of alienated from and sort of stigmatized also from this, from the people, the society that they live in, their friends, their family members. And because of this alienation, they sort of disengage themselves from the community activities. So, this also has a very detrimental effect on the individual. And can anyone give me an example of what can be the economic consequences here?
Loss of a job.
Being bankrupt, loss of job.
Yes, very correctly said. So the substance use problem can cause, the loss of employment, and because of, the individual not being able to give his or her best, long absence from the jobs, which sort of result in a financial crunch for the families. And also, there would be debts or loans which needs to be paid off. So these are some of the consequences, which are very let's say in every aspect, as we have covered here, these are some of the consequences of substance use. Roshan, next slide, please. Okay, so this is about the differing physiological responses in women. Now, can anyone just tell me why is it that women respond physiologically different in when it comes to their male counterparts? You know, women who abuses substance or anything. Can anyone just respond to why is it like this?
Tolerance level are different for
Sorry?
tolerance.
Yes, yes, very correctly said, Luella. Firstly and foremostly, because of the biological differences, and as we know, women and men are built differently. And also, women tend to be physically smaller when it comes to the male counterpart. And there are other there are fluctuation of hormones when a woman attains puberty. So all of this sort of interacts with the substances that they have been abusing, and it causes a lot of problems to them. And also, other than that, women tend to process, metabolize, and eliminate the drug of abuse very differently from their male counterparts, because of which the long-term effects are more prominent in women as in comparison to men. Also, we can say, well, like the first point being the develop physical problems related to substance use sooner. Yes, the physical problems here would refer to like women can sort of have physical effects on their heart and the blood vessels, and even the brain chemistry also changes differently in women in comparison to them in comparison to men here. And as we can say that, because we talked about, women who are abusing substances will have issues related to, menstrual cycle, with related to menopause, with related to fertility. There is a high risk associated with the sexual and reproductive health as well. And the risk of experiencing psychiatric comorbidity is much higher in women, because they may experience panic attacks or anxiety or depression, all of this, so on and so forth. And the second point being escalate to addiction more quickly. The term that we use is telescoping. Can anyone tell me what do they understand by this term?
As as per the women physical system, I think the women tend to grow the tolerance much quicker than men.
Yes, very true, Avjit. So it's basically, let me just tell you what the term means. It is a term which is used to describe the accelerated progression from the initiation of the substance use to the onset of dependence and the first admission to treatment. So basically, the thing is, what it means here in simple words is, despite having lesser amounts of substances and also for a very short period of time, women tends to move on to the next level of addiction when it comes in comparison to their male counterpart. And also, women who enter substance abuse treatment at this time, typically they present a more severe clinical profile, as in more of medical problems, social problems, and behavioral problems, and so on and so forth. Next slide, Roshan, please. Thank you. So here, again, it's a continuation wherein much of the research has been done on women who have been consuming alcohol. But there are research which suggests that a similar pattern of rapid progression can be seen with other illicit drugs, as in like cannabis or, in opioids, all of this. So the thing is, women tend to enter into the substance abuse treatment much more earlier than men. If timely intervention if they have been sort of, identified and thing has been done on time. Next slide, Roshan, please. Yes. So women who have been abusing drugs and who plan to become pregnant and so they are not only putting their own life at risk but also the life of their unborn child. Now the substances that they abuse will have detrimental effects on the fetus, so it can range from low birth weight to developmental, behavioral and cognitive deficits. And exposure to marijuana, cocaine, it can result in fetus or the child having impaired attention, problems with language and learning skills, also behavioral problems. Similarly, exposure to methamphetamine can result in fetuses having restricted growth, and also poor movements in babies. So on to say that the heroin exposure, there is a risk of opioid withdrawal after birth. And as we saw earlier, that low birth weight is a very important risk factor which can result in developmental delay, because every child has to sort of in some or the other way they do cross the developmental milestones. So women who use, or the expecting mothers who abuse substances, so their children, or the fetus in the mother's womb can, they can have all of this. Roshan, next slide, please. Neonatal abstinence syndrome. Okay, can anyone tell me what do they understand by this NAS, that is neonatal abstinence syndrome?
3 more minutes.
The baby also experiences a form of withdrawal.
Yes, very correct, Luella. So here the thing is, when the woman has been using or abusing drugs or substances regularly during pregnancy, or has been abusing for a very long period of their life, the baby go through the withdrawal symptoms after birth, and this condition is called as neonatal abstinence syndrome. Now, this syndrome is seen with women who consume opioids, alcohol, caffeine, and also some of the prescription sedatives. Now, the type and the severity of the baby's withdrawal, it depends on some of the most important factors here. Firstly, it depends on the kind of drug that the mother has been abusing. It also depends on how long and how often she has been taking it, and how her body sort of breaks down that drug, because as we know, some women are wired differently in a manner wherein they metabolize and eliminate drug of abuse in a very differently in comparison to the male counterpart. And also, like the pregnancy, whether it is full term or the child is born prematurely, all of this contribute, or let's say all of this constitute this syndrome. And the symptoms of NAS in a newborn can either develop immediately after birth, or it can take up to 14 days. So some of these symptoms include blotchy skin coloring, diarrhea, high-pitched crying, fever, increased heart rate, poor feeding, rapid breathing, seizures, trembling, vomiting, etc. Next slide, please, Roshan. Okay, now differing physiological responses in youth. Can someone tell me why, how is it different in youth when it comes to youth? Let's say starting from 14 years, the adolescents to the young adult. How is it that, it differs there?
Because their physical and psychological development are not completed in that time.
Yes, very correct, Avjit. So basically, as we know that, yes, somebody was saying.
Oh, I was about to say the brain is still pruning stage, that adolescent stage.
Yes,
So it will
yes.
take adult brain to fully functional by the time they reach to 25 years.
Yes,
So
yes, very
before
true.
that, every drug has effect on our brain. So yeah,
Yeah.
that is the cognitive abilities and emotional aspects will get disturbed when they are in substance use.
Yes, very true, Devika. So as we know, the adolescence is a risky period, and at that point of time, the individual is going through a major transition, whether it's biologically, emotionally, in all aspects. So, abusing drugs or starting the use of drugs, be it for recreational or, sort of occasional or experimental, it can have a very significant impact, and also can lead to the individual developing substance use related disorders. Now, the thing is here, young people, they are vulnerable to physical and social problems. That means it's all related to, let's say, the academic problems, impaired driving, violent behavior, risky sex, and also SUDs. There are significant brain changes that happens when person of individual at a very young age is exposed to any kind of such drugs, and it can have impact brain circuits which involve learning and memory, decision making, behavioral control, emotional development, and so on. So basically, if you see here, people like whether it is for under the peer pressure or whether it is for them to be accepted in the group, people who take some drugs like let's say marijuana, particularly young people, they take the dosage which may induce psychosis in vulnerable individuals. Now here vulnerability is can be, we can see it in the context of genetic link, or let's say predisposed, the individual, if they are predisposed to developing some kind of problem, this can be the triggering point, sort of, and so on. So is the case with ecstasy, which appears to make individuals more likely to experience mood disorders later in life. Roshan, next slide please. Yeah, so as we also know that it's not limited to any age group, or it is not limited to any one socio-economic strata of the society. It is very rampant, and therefore awareness about the effects of the drug and how it can have an impact on all aspects of an individual's life, the timely intervention, all of this can help in controlling, or let's say bringing down the cases of people abusing drugs. Next slide, please. Thank you so much. If anyone has any questions, please go ahead.
You don't have time to take questions now because it's time limit is over. Aditi ma'am.
Yeah, thank you, Ramya. Little bit overshot time actually. So very nice way to begin by asking many participants questions. I like the way you made it interactive. You gave a whole lot of examples, made very complex matters simple. Your explanations are very, very simple. One more thing, you can make the slides little attractive, probably. They were very clear. I'm not complaining. I'm just giving you an extra hint that next time, make it a little attractive.
Yes.
But yeah, overall, I liked, except that you overshot a little bit of extra time.
Okay. Thank you, ma'am.
Francis?
Yeah, Ramyaji, you did very well. Simple. Tried, gave examples, tried to give examples for each one. Explanation was good. However, I would like to say participant management, engagement. See, when you ask question, there will be too many people to answer. Since the given time is 15 minutes, you must able to restrict some of the contributions maybe, because you cannot go on and go on. That may be the reason you took a little more time. That's fine.
Yes,
but
sir,
you are a
I
good trainer.
understand.
Very
I
good.
understand.
Okay. Very good.
Thank
Very
you.
good.
Thank you so
Excellent.
much.
Yeah, a very good point Francis made. And you can ask the remaining participants that please write it in the chat and we will have a look at it later.
Yeah.
So you don't curb down somebody. You have everybody telling you because you made
Yeah.
it so interactive. Everybody felt like sharing.
Okay.
So don't say
Yeah.
don't share. But yeah, you say because of the time we'll move ahead, but keep
Yes.
that in
Yeah.
the chat and we'll take
Yeah.
it. So that's a
Yeah.
good way of doing it.
Yeah.
Very well.
Yes, ma'am.
Good.
Yeah.
Good. Keep it up.
Thank you, sir. Thank you, sir.
Now what is clear to me is that all of you are very capable people. So we should start something different and plan for a training programs. Maybe you will conduct training program for us. We will listen to you. That's good. Okay. Good.
Thank you, sir. Thank you.
Who's the next one?
Can I go, ma'am?
Yeah, sure, Jyoti. Go ahead.
Thank you, ma'am. Give me a minute while I pull up my slides. Oops. Miss slide visible.
Jyoti is presenting. Okay, good.
So is my slide visible? Anybody can?
Yes,
Yes,
yes.
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 Okay. Thank you. So, good evening, everybody. I'll be talking about the continuum of care for substance use disorder treatment today. The word continuum means something that keeps on going, changing slowly over time. And here, by the continuum of care, we mean treatment and other services provided over time. So before we get into the topic, I just want to know whether the profile of your clients look like this or this. Anybody?
The second one.
And why do you think so?
Different gender, different communities, different culture, different race.
Wonderful. So we agree that every client is unique. Motivation. We are having people from different genders, from different communities. So they will have different needs also and different level of motivation. So before we move ahead, let us discuss a little further. Can somebody read the first statement for me, please?
SUDs often take the course of a chronic and relapsing disorder.
So is that true or false?
Yes, true.
True.
False.
True.
Okay, so we have a false and more of true. Which one are we going with?
It's true.
True.
True. True.
True.
One, please.
Let's go with true, ma'am.
Thank you. Second one.
Effective treatment attends to multiple needs of individuals,
True.
not just their substance use.
True.
True.
Let's go for the third.
Counseling has no role in helping patients avoid high-risk behavior.
False.
False.
Let's go for the fourth then.
Treatment services have to work with the person served over the long term, often for years, sometimes during the person's entire life.
Yes, true. Sometimes it happens.
Agree that the SUD services serve their clients for an extended period of time and sometimes the entire life. So the continuum of care refers to the whole range of services a client can receive directly from a treatment program, coordinated by the treatment program, and the recovery-oriented systems of care. So basically, the objective is to provide care in a seamless and coordinated manner across a variety of settings, different modalities, different programs, and recovery-oriented systems of care, so that the client may not fall through the cracks in the care system. So we must remember that recovery is the ultimate goal at each stage of the treatment continuum. and linking the client and the families to recovery-oriented system of care helps prevent relapse and maintain recovery. And the recovery resources, as we all know, include personal, professional, and indigenous community resources such as mutual support groups, the spiritual groups, or the faith-based groups. Moving ahead, this is the care path, a path that a person may take in the recovery process to access services and interventions offered by a single entity or a network of entities. So to understand these services, we'll take the help of a true case study. Can somebody please read the case study for us? Any volunteers, please?
Miss Shine has seen Mr. B in a parking lot of a cinema hall with takeout food boxes, used syringes, and soiled clothes littered around. It seems that Mr. B has been living there for some time. While parking her car in the morning today, Miss Shine realized that Mr. B was limping and talking to himself. Miss Shine works as a counselor at the medically assisted treatment facility for opioid use disorder. She decides to reach out to Mr. B.
Thank you so much, Chandra, if I'm not wrong. Thank you. So now we have this case study, and as you can see that Ms. Shine is a counselor, and she goes and talks to the outreach worker. We call the outreach worker OW to go and meet Mr. B. The outreach worker establishes contact, he builds support, trust, he provides the needed healthcare information, and identifies the problem, the SU problem, and motivates the Mr. B to treatment. So at any point of time, do you think the outreach worker tried to make a diagnosis?
No.
No. Thank you so much. So the next, when the client we are talking about, Mr. B, he follows the suggestion of the outreach worker, and he visits the rehab, and therein he gets a quick assessment made, which is the severity of the problem and the urgency to attain the treatment. And he suggested that an inpatient inpatient treatment is the right approach. The main dimensions of clinical relevance here are the Mr. B's substance use, Mr. B's physical and mental needs, Mr. B's preparedness for behavior change and motivation, and recovery atmosphere. So on this basis, the initial assessment is made. So once this assessment is made, the intake counselor provides information about the treatment, the facility, and explains the informed consent form to Mr. B. And after Mr. B has the required information, he decides to avail the treatment and he signs the form. Next comes the time for the comprehensive assessment. So the comprehensive assessment is made by a multidisciplinary team of doctors, counselors, and peer educators, and they determine the needs and sources for the treatment, the possible routes to progress in recovery. So information is gathered from collateral sources also, like the friends and family, only after Mr. B permits. So you can see that at any point of time on each step, the autonomy and confidentiality of the client is respected. So if you are the counselor, as the question goes, what 2 questions would you ask Mr. B?
Because the client is limping and talk to himself, I would ask medical and psychiatric history.
Wonderful. Any other inputs, please? Any other questions which you feel should be asked at the comprehensive assessment stage? Do you think family or social component is important because he was, parking lot?
Also his economic state?
Yes.
Because he's living on the street.
So these are the domains of ASI I have mentioned on the right-hand side. So these are the guiding domains which we will be using to ask for using during the comprehensive assessment. Okay, on the basis of the comprehensive assessment, the treatment plan is finalized. So the treatment plan, as you know, is an individualized outline of the treatment and services which will be provided to Mr. B. It is the information which is collated from the assessment the treatment plan is made in collaboration with Mr. B, the counselor, as well as the other treatment providers. And the understanding is that if there is a need for improving the treatment plan, it would be done as and when required. And basically, we are talking about the need assessment, we are talking about the goals, the objectives, and the interventions. So as to help Mr. B reach a goal of being drug-free in his situation as of now. Any questions till now, if somebody would like to ask? No? So then I ask a question. If you were the counselor, would you make the treatment plan for Mr. B?
No, the plan should be made together.
Yeah, in collaboration with all the parties, especially the client. So Mr. B did well in the program. He stayed with us for 3 months and he completed his treatment and he is good to go. So he was asked by the counselor to keep taking his prescribed medications for HCV and depression, and asked to go and for the follow-ups to the partnering facility. He was given a follow-up regimen which by the rehabilitation center, so to stick to, and he was motivated, he and his family was motivated to remain connected with the recovery support groups and build new support. So basically, in aftercare, we provided continuous support for his requirements, Mr. B's requirements, and already the recovery network was present, so he could actually go out and enjoy the support of that base which we had made. We and he had made together. That was aftercare, and all the facets of the aftercare, that is the financial, educational, physical, emotional, all the facets of the aftercare were kept into mind. So keeping the financial part, in the case management, it was made sure that the counselor was the case manager as well. So the Mr. B had expressed that he would like to do mushroom cropping once he is discharged. So the case manager coordinated with the agriculture outreach facility and asked got him involved in a training program there, so that he has a purpose in life and he can get reintegrated into the mainstream of the society. So this is, and be financially fruitful. So this is how we did the case management for Mr. B. And of course, the reference and the linkages with the partnering agency was taken care, coordinated by the counselor, so that the continuity of treatment was maintained. So these are all the services provided on the continuum of care in this particular case study. I hope I did justice to all the components of the care path. Would you be interested in doing the questions with me, or I'm open to take the questions from you? The floor is open for the questions, please.
We can do it together.
Okay, so let's see. First question, who will read for me?
Comprehensive assessment should be preferably carried out by a multidisciplinary team.
And the second?
Informed consent is obtained from the client.
Obtained before the treatment?
Before.
The planning. Before
Or
planning.
Okay, before treatment. Yes.
So when are we doing?
Before assessment.
Before initial assessment.
Before the comprehensive assessment. Initial assessment is just, we are just judging the severity of the problem. So now once we have the severity, we know there is a criteria we have, that the person is going to come for the treatment, that we are going to go for the detailed assessment of this person, so that the client will come up with intimate information about himself or herself. So this is when we need all that paperwork. We sit and do all that, which is very important. That is the first step to so that the client knows what he is stepping into. Third question, please.
Initial assessment is carried out to determine the severity agency of client's problems.
Exactly, Nazri. Fourth.
Screening, brief intervention, and referral to treatment is conducted at which stage of the treatment continuum?
Outreach is birth.
It's right there. Recovery ultimate goal at which stage of the treatment continuum?
Every stage.
All stages, yeah. All stages.
Thank you.
Question 4 looks like a 10 marker.
All yours, ma'am.
Thank you, Jyoti. Lovely presentation. Basically, a couple of points started with a very interactive activity, very calm and good tone of voice. I liked the way you had a case study to explain the entire gamut of quantum of care or the care pathway. Also had a kind of summarizing activity in form of questions. Now, my only hitch here was you started with an interactive activity again with true and false and ended perfect, very brilliant way of actually winding it up. Only thing is, if somebody says it's true and somebody was said false, then you should explain why it is true. That little explanation for each statement is necessary, because the false person doesn't know why you are saying it's true. You just moved on. I probably because of the lack of time, I know, but just
Yes,
all of you keep it in mind.
It is such a vast topic. I was so tense.
So give one-liner explanations to all the questions or true and false you have. Even at the end, when they say comprehensive assessment, quickly say in one-liner why comprehensive assessment is important at that time. Or what is, you gave an example, actually you when Shalini said something, you explained her something. That was very good. So it clears everybody why that answer is correct. So that's the only hitch. Otherwise, great job.
Thank you, ma'am.
Yeah.
Francis,
Yeah.
fire.
Jyoti ji, very calm, poised. And you did explain things in a very simple language. It's clear.
Thank you, sir.
However, I would like to tell you 2-3 things, like, when you deal with so vast areas of, the portion was too big for you.
Yes, sir.
So you can abridge it, shorten it. That technique you can use. And what was good of you is that the way you asked questions, the way you answered the questions, that was good. You did engage the participants very well. On the whole, it was excellent presentation.
Thank you, sir.
By the way, to the whole group, I want to tell something, that informed consent you take at the time of intake. If it is for a treatment, that's the thing you must keep in mind. Without consent, we do not do or any interventions. Please just keep in mind that. That's all. Thank you.
That's
Thank
why
you.
I mentioned the intake counselor. So I
Yeah.
was editing my script so that I can
Yeah.
fit it
No.
to.
You did say, but I just want to clarify. That's all. It's clear. Very clear. Thank you. Okay. Okay. Good luck.
Who's the
Thomas
next
G.
one?
This is not here. Can we give 5 minutes break?
Yeah, sure.
Are you struggling with dandruff?
Yes, ma'am.
Yeah, who's going next?
Ma'am, I'll start my presentation, ma'am.
Okay, Nima, take over.
Nima Matthew.
Sir.
Go ahead.
Uh,
Go ahead.
Is it my slide is visible, sir?
Yeah.
Yes.
Yeah, put it on a PPT mode, na, Nima?
Oh, okay, ma'am.
Slide.
Now, ma'am? Yeah.
Yeah.
So, good evening, everybody. I'm Nima Matthew. I'm going to present on screening and brief intervention. So, let's start with the case study. So, can anybody read this case study?
Yes, there is a health center in college. In that health centers, they use to screen students for potential substance use issues. They use a validated questionnaire to administer all incoming students during their orientation. The questions include questions about their alcohol, tobacco, and drug use habits. One day, a new student named Sarah completes the questionnaire. Based on her responses, the screening tool shows that she has a higher risk of having a substance use disorders. It doesn't specify the exact nature or severity of the problem, but it indicates that there might be an issue.
Okay. So from this case study, what are the things, important things we can take it out? Can anybody volunteer?
One of it is to classify the level of severity, probably mild, moderate, severe severity
Okay.
of SUD. Yeah.
Okay. Okay.
This
They have used a validated.
Yes, of course. They have used the validity tool here, screening tool.
So it only assesses risk. It's not assessing the severity of the problem.
Excellent, excellent, excellent. Okay, okay. So they have used the validative questionnaire, and it has not told the severity level, but it has told there is a problem. So this this screening has allowed as the health provider to indicate, and it has initiated the discussion with Sarah about the substance use. And this can initiate us to ask more in-depth questions for the better understanding, and even it can help us to assess what intervention can be given next. So in this case study, it has not answered all the questions, but it has helped us to know there is a problem, and it has opened a door for the conversation to address the substance use concern. So, screening is a process that determines whether the problem exists or not, or the further assessment is needed. So, during screening, we have to use the validated screening tools to detect the substance use disorder and the level of risk they represent. And it also say the initial amount of action what we are supposed to do. So I'll ask you a question. Why do you think that screening is needed? Why it is needed?
To evaluate the level of addiction and other things.
Okay, so to see the level of addiction. Good. Anybody else?
So
I think it's more about the risk, whether there's a risk or not. It's not so much about the level of addiction.
Okay.
It is
Yes. So
it is also used for inclusion and exclusion criteria.
Yes.
Whom we have to address. I mean, the present problem is there, and whom we have to exclude attending the issues. Whatever the screening will help us to determine whether the problem is there or not.
Yes, excellent, excellent. So the screening is needed because this problem is worldwide, and it is associated with the morbidity and mortality. And early identification and intervention can result in making connection between the health and the substance use, and we can identify the problematic substance use, we can reduce the substance use, and we can motivate the client for the get admitted for the treatment. Okay. So let's see the difference between the screening and assessment. So can anybody guess what is the difference between the screening and assessment?
Screening is just screening, but assessment is diagnosis. Screening is not for diagnosis, but assessment we can make diagnosis.
Yes, yes. For example, the screening will say the person might have a fever, but the assessment will say the exact temperature and what are the step of treatment should be provided. So screening says whether the problem exists or not, what are the follow-up thing has to be done. Assessment will say the nature of the problem and what level it is and what are the intervention should be given for them. So tips for the screening. Of course, non-judgmental. While doing this screening, we should not be judgment. We should be respectful. We should not use any stigmatized languages. And screening should include the health habits of the client. And the client response to the screening questions are most accurate when the client is not intoxicated and when the written assurance of confidentiality given by the counselor, and while interviewed, the honest report is given to them, and the word and the objective are very clear, and the standardized tools are used. Even we can provide them with the memory card, or we can even give the response in a card based. So when it comes to screening tools, internationally validated instrument are two. That is audit and assist. These two things I'm going to explain. So when it comes to audit, it's an alcohol use disorder identification test. It has 10 items in the questionnaire and it can be completed in 5 minutes. So this tool was developed by WHO, focused on alcohol-related problem is hazardous usage, dependence symptoms, and harmful alcohol use can be elicited with this tool. So when it comes to assist, it's an alcohol, smoking, and substance involved screening test. This was developed by an international group of SUD researchers for the WHO to identify the substance use and related problems in primary health care and in general medical care setting. It has 8 questions on alcohol, tobacco, and illicit substance, that is injection and all the other drugs. Though assist informations, it will give the information about the substance use in the patient lifetime and in the previous 3 months, problem related to substance use, risk of current or future harm, and depends and injecting drug used or gathered. These are the information can be gathered while using these tools. So while using these tools, the client will fall under this 3 category. One is lower, moderate, and higher level. So when it comes to no or lower risk, that is we can just appreciate the client and we can just give the basic information about the addiction. For example, if you come to know the client family has an history, if his father or mother or grandfather or maternal uncle, if somebody in this family is having an addiction issue, then we have to talk about the genetic component of addiction to them. When it comes to moderate risk, there we have to provide a brief intervention. When the client falls under the high risk or active addiction, then we have to go for the further assessment and we have to provide referral for treatment. So next we can see about brief intervention. So brief intervention is focused on increasing the insight of the person and awareness of substance use and behavioral changes. This can happen in one session or even multiple sessions of motivational intervene and through substance use disorder or the professional or the peer staff, whoever is trained in a brief intervention can provide this a brief intervention. So let's see the component of brief intervention. So it's a frame. F stands for feedback. When it comes to feedback, how we can give a feedback to the client? Can anyone volunteer?
Feedback after clients answer the questionnaire. So we ask the patient whether they want to know the score of the questionnaire. As for the feedback.
Okay. So here we have to talk about the score, as well as we have to talk about their substance use and its consequences. For example, we can say that based on your recent alcohol use, you have missed your work 3 times in the past month, and you have even had 2 alcohol related accident. This is affecting your job and safety. Like this, we can give a feedback according to the client, whatever the problem, we can just give feedback like. So next, R stands for responsibility. So what comes in your mind when you think what is responsibility in brief therapy?
Making the client understand that he is completely responsible for the change that he might want to make.
Yes, very good, very good. So we have to encourage the client to take responsibility for the substance use which they have the problem, and in their recovery also they have to take a further step. For example, we can say that it's important for you to recognize that drug use is a choice of you, and you can make a decision, and you can take a responsibility to change that, and you can modify your behavior. It will help you. Like that, we can just motivate the client to take responsibility. Then when it comes to advice, anybody?
I think we can tell clients that the best client can do is either to cutting down or to reduce.
Excellent, excellent, excellent. Yes, we can just tell them like you can just lower your risk of health problem, or you can even improve your overall well-being. It's advisable to cut down the alcohol consumption, or even you can consider cutting down totally. Like that, we can just give a advice. So when it comes to menu, what do you mean?
There's 2 more minutes.
Yes. Anybody? Okay, when it comes to menu, we should present a range of options for changes and allow the individual to choose what suits them. For example, we can discuss with the client about the treatment option, detoxification, counseling, peer support, and harm reduction strategy. And we can ask the client, which of these options could you think that will be most useful for you? Like that, we can just give lots of menu to choose the client whatever suits them. Then E stands for empathetic. Always empathetic is very important when we are approaching with the client, because the client will realize that, and he feels that this counselor is understanding my struggle and challenges. And last is self-efficacy. This is, we have to help the client to build their own self-efficacy by setting an achievable goal and increasing their confidence in making changes. For example, we can say, let's work together to create a plan and include smaller manageable steps that can reduce your substance use. Your success is achievable goal, and we can boost the confidence in the client and motivate them to do some behavioral changes to achieve the goals, whichever they have set. So that's it. Thank you. If any questions, you can just ask.
All right. So very well done, Nima.
Thank you, ma'am.
Yeah, so you used a case study to elicit responses, which was very nice. Validated and affirmed the participants' responses. You did that every time, which was nice. Very clear and simple explanations with lots of examples. I like the way you used the MI frames approach to BI, brief intervention. It worked out well. One thing is self-efficacy is actually picking up from the past successes of the client. So asking him about how successful he was, or when has he remained abstinent, or how did he do that particular thing, and then you affirm that and say, wow, you can do it actually. So this time also you can do it. But yeah, your explanations were very nice. Overall, very good performance.
Thank you, ma'am.
Nimaji.
Yes, sir.
Yeah, definitely you did very well. What I liked was the way you answered participants' questions. You had a PPT, a slide to show the answers very clearly. The knowledge level is very good. A little bit of more of participant engagement, maybe more added to the flavor. Demeanor is good. Your supervision of the environment was also good. As Aditi ma'am said, you used the frame to explain about the brief intervention. That was fantastic, because that is which we always use to explain how we can do a brief intervention. So excellent job done. Thank you very much.
Thank you, sir. Thank you all.
Who's next?
Who's next?
Myself, ma'am. Liba.
Yeah, Liba, go ahead. Go ahead.
Do you want me to share the slide?
Yeah, yes. Hello, everyone. I will be presenting on the topic psychoeducation. Before going to the slides, I would like to hear from you. So what is your understanding about psychoeducation? Can anyone say?
It is re-educating the client.
Okay.
On certain important topics which helps them in recovery.
Or it can be giving
It
more
is-
information on certain topic.
It is providing information about the disease and the recovery process.
Yes. Okay. True. You all are right. Can I have the next slide? Yeah. See, as you all said, psychoeducation is a term which is used to educate about substance use disorder and its consequences and the recovery, all the things to the clients as well as their family members. Here, when we plan about psychoeducation, we always focus on pass the information, pass the scientific information on addiction. See, many times people are not aware about addiction as a disease. See, family members are not aware. It's a brain disease, the nature of disease, it's progressive in nature. So many times they are not at all aware about that. So in our psychoeducation sessions, we should include facts about addiction, then issues related to qualitative recovery. See, after the treatment, when the person is in recovery, he may face a lot of issues. For example, I can say that if the person may have co-occurring mental disorders, if he is not taking care of that, it can be hinder his recovery. Or he may be an unemployed person. If he is not engaging himself, it can be hinder his recovery. Or else we can say that he has not a good interpersonal relationship with his family. Even that also can hinder his recovery. So issues related to qualitative recovery. Then facts about relapse. We have to educate them that relapse is a part of the disease and relapse is always preventable. There are certain warning signs and symptoms for relapse. Once you see, for the family members, we can educate about the relapse. Then after the treatment, suppose relapse happen, what they have to do. So all the things we have to include it in the psychoeducative sessions. Can I have the next slide? Yeah. See, here I have put few things that while you are planning a psychoeducative session, you can keep these things in your mind. See, as you know, psychoeducative sessions start at the beginning of primary treatment. See, we have already seen the continuum of treatment care. So in that, it will comes under the primary treatment. Okay. And when you are planning for psychoeducation for your patients, you have to decide on to whom you are going to do, for the patients or for the clients only, or you are going to do for the clients as well as for the family members, or you are going to running a parallel program for the clients and a specific means specific program for the family members. You have to decide on that particular thing. Then you have to decide on the duration and timing and all. See, suppose you are as a treatment provider, you are providing a 3 months treatment or 1 month treatment. So how long you are going to give the psychoeducative session? How many days? And each day you are going to give only one session or multiple sessions, and each session will last for means 1 hour or 1.5 hours. Likewise, you should have a plan on the psychoeducative session. You have to nicely you have to structure the psychoeducative sessions. And another thing, when we taught the content, so we can use audio visual aids like means videos, audios, then we can use the stories, and we can use a lecture mode. All those things we can use for passing the information, for the content information. And you can also plan for some kind of activities in the sense like we can ask them to have a small group discussion within the subgroups, or we can give some printed activity sheets and we can ask them to do that. So likewise, we can plan some kind of activities in terms of psychoeducation. Can I have the next slide? Yeah. See, here are some topics for psychoeducative sessions. I randomly put a few topics only, like a disease concept, then structuring personal time, then having a relapse planning, having a relapse plan, then how we can rebuild a personal relationship with the family. So these are few topics only I mentioned here. You can refer, you can, for further reading, you can refer UTC 2 module 6 resource page 6.3 for further readings. There you can see n number of topics for psychoeducative sessions. So far clear? Any comments? Are you following me?
Yes, we are following.
Yes.
Okay, thank you. Okay, if there is no comments or question, let's have a quick activity. So what we are going to do that, can I have the next slide, please? Yeah, so I'm going to do a breakout room. So you will get a 5 minutes. I know that it's a very short period of time, 5 minutes. So in the group 1, what you have to do that, you have to plan how do you conduct a psychoeducative session on the given topic. So for the group 1, effects of alcohol or drugs on the brain and body. Then for group 2, handling high risk situations. These are the 2 topics. Just have a means discussion how you can plan it, how you can structure, what kind of contents we can include in this topic. Okay, so Roshan, I need your help for having breakout
I'll open the
rooms.
groups. I've opened the rooms. I've sent a notification for 2 groups. They can join. Yeah. Five minutes, right? Yes. Jyoti, Sunisha, Jermaine, please join the groups. Yes, Liba. For 5 minutes, right? 5 minutes, right?
Yeah. So can I go to the next group? How
Okay,
can?
sure. Send the notification again.
Yeah. Okay. Thank you.
Yeah. Second.
Hello.
Yes. 1 more minute is there.
Okay, okay.
Yes, time's up. Yes, Yeah, close the rooms. Yes, Liba. Can you activate your audio? Your audio is not connected. Activate. Close the rooms, okay?
So extremely sorry, in between I got disconnected. So I think we have very less time only. So can anyone?
One minute. All have not joined yet. 40 more seconds.
Oh, okay.
So one group has.
We thought of saving Liba ma'am's time, so we just returned back quickly.
That's nice.
I think we can't hear anybody.
Solar back?
Not yet. 10 more seconds.
Okay.
Speak a little too fast. Give one more extra minute. Okay. Yeah. Everyone's back.
So one group can present. And
Haliba, I'm from group 1. We have decided we can give 1.5 hours session. First, the trainer will educate the client on each, from brain to digestive system and how each part, liver, stomach, and all, how it gets affected. And then we thought that we, as activity, we can give a human picture and ask them to mark in that, saying that these are the physical damages which they have, and brain damages, due to brain damage, what are the symptoms they have. They have to mark in that as an activity. And then at the end of the session, we thought we can give a homework to the client. Think about how they can improve those health issues. What are the steps they are going to take? So two points they have to mention for that. So this is what from group 1 we have discussed.
Oh, that's so excellent, Nima. Thank you so much. Any other add-on to these points from others? Any comments, any other add-on points on this particular topic?
No, these
If
were
not,
all. These were all.
Okay. Then we can go to the next group. I think we have time. So can anyone from the group 2?
Yes. So depending on the population, we can have different sessions for the following topics. Now we can have different topics. Some sessions can be taken with poster making, role play, where we give situations and ask how they can respond, and present case studies, sharing stories, how they can handle. Then educative session on high risk situations, identifying slippery days and making arrangement for them to stay. One of the member trainer shared about it. And we can also have games with the which it's high risk situations, how they can handle that. So I think 1 or 2 points I missed. We've made few more points also.
Okay. Thank you, Clara. So others, do you want to comment on this?
Yeah, we also discussed about making posters to create more awareness, and also sharing of experiences and stories, personal experiences and stories. And also initially to have an interactive talk to open the topic.
Okay. That's nice. Okay, thank you all. So on a concluding note, I would like to share that psychoeducation is an inevitable, significant part in the primary treatment. See, from my experience, I can say that you can see the changes, how the person's changing their attitudes, their perceptions, their behavior. You can see in front of your eyes in a very clear, in a visible way. So it's an important part of primary treatment. If your treatment center has this kind of psychoeducation program, you can always, restructure that also. Whenever you get a lot of new ideas, new evidence-based practice, you can apply in your primary treatment program also. Thank you so much. I think I have taken a little bit more time. Sorry.
Yeah. Thank you, Liba. In spite of, you took a little more time, but in spite of doing breakout rooms, I think you did very well. I think I was a little tense. How is she going to manage a breakout room in 15 minutes? But you did really, really well. One thing I liked is very clear and simple explanation initially. Very calm tone of voice. One thing I liked was she visited both the groups when she did the breakout rooms. It's very important that you visit, because in one of the groups, there was a lot of discussion on what is high-risk situation, whether it's prevention, whether it's substance use, whether it was when a person is relapsing. So they had a very fruitful, I was in that group, so I heard it. One thing is breakout rooms make people talk and discuss, and that happened in her groups, which was great. But Lima went and explained what she meant by high-risk situation, and I think then they came out with their own answers. So great job.
Thank you.
Okay, Liba, you did well. Fine job. Very good explanations. What I like the most is you used the break room, and you also, like Aditi mentioned, you visited the rooms and then you checked everyone. That was something good. One thing what I would like to tell you is that when you use break rooms like these techniques, you need a time, but you did manage with a very limited time, even though you little bit exceeded, but with that break room timing, you did very well. Your experience in the field of addiction, you as a counselor, did reflect in the way you discuss the things. That was something notable. Very good, excellent. Keep it up.
Thank you, sir. Thank you.
All right, who's going next? We have one more person to go. Do we have anybody today?
Ma'am, you had asked me to present, but it will be good that if I present on my scheduled day.
Why you're not ready today, Rajesh?
My assignments, I was just engaged today. I couldn't get myself to free, because I had my own assignments here.
Okay.
So I have a very short preparation, but it won't justify the class today. So on 7th, I can present a first person to be there.
Okay.
Jimmy, can you activate your audio if you want to present?
Who's presenting?
WhatsApp, I saw a message that he wanted to present.
Who's that? Jimmy?
Gimen.
Oh, Jimin. Gimin. Is he here? I can't see him.
He's here, but audio is not activated. Is there anybody else?
Maybe his internet is not good. I can't see his sign.
15 more minutes.
That means we had only 5 people today.
Yes, we had only 5 people today.
What happened? What's happening?
Yeah, we have only one more day, so I don't know how we are going to manage.
Yeah, maybe we take a little more time on 7. If it is okay, we can finish it on that day itself. Think of that way. Ronnie.
Yes.
Yeah, allocate a little more time and then finish it off that day, because we may not be finding time to finish it because we have other business to do.
Also, the technical session, we're supposed to have a technical session, right?
Yeah. So that's
That
why
will
I
be
said
after that. That will be after we finish.
there are a few more to finish. Yeah.
I think there are 26, no? Roshan?
Yeah.
Not sure.
There are 26 names.
Yeah, there are. So
I don't know how we'll
so
do
on
it.
7th, maybe, yeah, on 7th, we may be having a little more time extended and then ask everybody to present on that day itself and finish it off. If
Yeah,
anybody
we'll
cannot do
require
it, then don't give them a chance.
1 more hour extra.
Yeah.
Okay.
Yeah, probably. You may start a little early, then you can finish it. But otherwise, we cannot extend it. Anyhow, you discuss with Dr. Thomas. Okay.
All right, then.
All right.
Then we can close for today, no? If nobody is
Yeah,
there.
yeah. Yeah, yeah. We can close it for. Ronnie,
Yes.
Ronnie, can you hear me?
Yeah, you
Ron
can.
is not here. It's Roshan.
Roshan is here.
Roshan. For Liba, I have not marked the rubric because I have some problem with my mouse. So I will mark it later and give. Okay.
Okay.
Okay. Right. I think we can finish it now and then announce it the other way. Discuss with Dr. Thomas and then finalize.
Okay.
Okay.
How many presentations are left?
We have 26 according to me, and we have only done 17.
Okay,
Oh.
9 left.
Big number.
9 more to finish.
9 more to finish.
Maybe you will able to finish if you give a little time, extend the time on Thursday, and then we will able to finish on Thursday. Sorry, on 7th.
But then we start early, Francis, not after 8.
Yeah. We must start at 5 o'clock and then finish it off.
If we are ready to start at 5, it's okay. Otherwise, not after 8.
Yeah. Correct. After 8, it will be difficult to start.
Yeah. 5 o'clock is okay for me.
Yeah.
Ma'am, 7th, I'll start first one.
Meeting.
Yeah, anybody can go first, no issues.
I will do it first, ma'am.
So, Roshan, will you discuss with Thomas? I'll also discuss.
Yes, ma'am.
We can start little early at 5.
5
Finish
o'clock,
it off. No?
Yeah, that will be better.
Yeah,
Is everyone okay with that?
So all those who are presenting on the last day, maybe 5 to 6, we can keep people who are not presented on their dates, on the day they were supposed to.
Yes.
Thomas has that sheet of paper, so we can put it in the WhatsApp group.
Okay.
All right, then can we call it a day?
Okay, ma'am.
All
Thank
right.
you.
Bye,
Thank you.
everyone.
Thank you, ma'am.
Bye, everyone.
Have a nice
Bye.
weekend.
Thanks,
You
sir.
will.
Bye.
Bye.
Bye.